Hello, everybody. We recently hit 1,000 subscribers, and I just want to say thank you, everybody, so much for being a part of the journey. My only goal in making this content is to help make Step 1 studying a little bit more fun and a little bit more easy. If I've accomplished that, then I'm a happy man. Just wanted to start the video by saying I'm super proud of the progress that you've made. Make sure in dedicated period to just breathe, find joy in the journey, and treat yourself as nicely as I know that you're going to be treating your patients someday. Okay, so in our first question, we have a 3-year-old girl who has pale skin, light hair, photophobia, and nystagmus, despite sunblock, has normal vitamin D and calcium. What explains these findings? The answer is deficiency in the production of melanin. So the pathway to get to melanin involves first tyrosine, next dopa, and then lastly the melanin, and that's via the tyrosinase. Okay, so that's the pathway. And if you have a mutation in this guy right here, then that means that you can't make any melanin. And in these conditions, you have the melanosomes are present, but the melanin isn't. And if you don't have any melanin production, that means that since the sun is a deadly laser, the sun is going to be shooting down all these UV rays and you're not going to have protection against it. And so the eyes and the skin are going to have underdeveloped pigmentation, and you'll have some visual defects and you'll have sun sensitivity. So the buzzwords that you're going to see on step 1 for this are going to be photophobia and blisters with the sun. And that's just due to the no UV protection because you don't have the melanin. Also, the translucent iris, the nystagmus, that's because there's no melanin in the retinal pigment epithelium, and so you get abnormal vision development. And these people will put on a bunch of sunblock and they will still have pale skin, and that's because this is a genetic condition, right? It's not environmental, and this is a problem with your pigments. All right, so some associations would be like oculocutaneous albinism, it's autosomal recessive inheritance pattern, and it's often that tyrosinase gene defect. And of course, you're going to have a really high risk of skin cancer, unfortunately. Okay, so we have in this question a child who's got photosensitivity, pale skin, nystagmus, normal vitamin D and calcium, and also normal melanocyte number and melanosomes, but there's just no pigment inside, and so it's a defect in that pigment pathway. And that is why our answer to this question is deficiency in the production of melanin. Transfer would cause hyperpigmentation. The melanosomes are present, so that's why it's not B. C would cause hypo, and it wouldn't have the eye signs, and E would not be albinism. And so the kind of lesser known fact here is that melanin has some other functions, including shaping how we see. You got to have pigment in your eyes so you can block out the sun. So the bottom line is you have that deficient production of the melanin, and that causes photosensitivity, and that's why we have albinism in this patient. All right, in this question, we have a 72-year-old woman with COPD who develops pneumonia, and despite ciprofloxacin, she does not improve. Genetic testing shows a mutation. What structure is altered? Ciprofloxacin is going to target the DNA gyrase. And so if you mutate the DNA gyrase gene, you have some resistance. And ciprofloxacin is a fluoroquinolone, and that's how we know that it stops this DNA gyrase. And the role of DNA gyrase is to essentially untwist the bacterial DNA during replication. And so if a bacteria mutates the DNA gyrase gene, then the drug can't bind anymore, and so you can't be treated. The DNA gyrase is pretty much the same thing as bacterial topoisomerase 2. And its job is just to relieve all that supercoiling that happens in bacterial DNA binding. And this is totally essential. Your bacteria cannot replicate DNA without it. And so you give them a fluoroquinolone, like ciprofloxacin, and it targets that DNA gyrase, and the topoisomerase 4, by the way, but that's not important. And so it just binds and it stops the DNA from unwinding, and so the bacteria then can't divide, and so it's bactericidal, it kills it. Okay, so here's our brief explanation and also our trap answers and why they're wrong. Love for you to take a second and look at that. And another thing is Pseudomonas aeruginosa is going to have that grape odor and also the blue-green pigment. There's a really good sketchy on that. I think it's worth watching if you can get your hands on it. Cell wall is the target of the penicillin cephalosporins, not the fluoroquinolones. Outer membrane, no, this is in gyrase. DNA-dependent RNA polymerase, that'd be rifampin. R for RNA polymerase, rifampin R. Lipopolysaccharide would relate to the immune response, not to antibiotic resistance. So Pseudomonas is a super drug-resistant bacteria. Basically, the most important point here, and I'll kind of go to this scene, is that Pseudomonas is a bacteria that can mutate the DNA gyrase gene, and then the drug can't bind anymore, so you can't do that treatment. All right, so think of the topoisomerases, the supercoiling, the DNA gyrase, and you'll get this question right on test day. All right, let me know if you like this new background color. In the next question, a 24-year-old man presents to the clinic with complaints of painful sores on his penile shaft and a surrounding redness that started 3 days ago. He's also got some mild itching and dysuria. That's just like pain whenever you're urinating. And there's a history of an occasional fever and inguinal lymphadenopathy. He is sexually active with multiple partners and uses condoms inconsistently. He's got some clusters of the erythematous vesicular lesions on the glands in the shaft of the penis. And erythematous is just that reddened kind of color. Basically, doctors got to be fancy, and so we have to find a way to say inflamed, red, and this commonly is just going to be associated with like infections like bacterial, viral, fungal, some allergies, and also autoimmune disorders and trauma, just erythematous, right? Redness of the skin, swelling, painful, itchy kind of stuff. You see it in a lot of things, so I digress. There is no urethral discharge. Lab shows multinucleated giant cells on the zinc smear. What is the diagnosis? All right, some things should be coming to mind here. Let's go through each one by one. Molluscum contagiosum. Sounds like a Harry Potter spell, but that one, it would be painless. So if I change that to painless, then you're in business, folks. But I don't know why, but like the M just sounds like ba 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 ba. I don't know, just like nice and welcoming and not painful. And so that's how I remember molluscum contagiosum is not painful. It's painless, and it's also dome-shaped, right? It's dome-shaped. Those are the umbilicated lesions, and there's no vesicles and definitely no pain from contagiosum. What about the chancroid? So those guys are painful, right? You do cry, right? They're painful ulcers. It's Haemophilus do cry. That's why I said do cry. But there's no vesicles on those guys, right? The lesions are going to be ragged and deep with a purulent base and unilateral lymph nodes that can suppurate, which basically means they fester, they form pus, they suppurate. And so that's not our answer, right? No vesicles. And here, whoop, we got vesicles, and that's why it's not the chancroid Haemophilus do cry, even though you do cry because it is painful. Unlike the M1, molluscum contagiosum, the Harry Potter spell, those guys are not painful. I mean, it just sounds like a nice little guy. D, primary syphilis, Trypanosoma pallidum. These guys are painless ulcers. They're pretty much the chancres, and they have the firm, clean base, and there's no pain, there's no vesicles, and there's no giant cells, and so D is wrong. E, lymphogranuloma. All right, that's going to be like the chlamydia, trachomatis, L1 to L3. Those would be small, painless ulcers, again, painless, followed by painful buboes. Those guys are the swollen, inflamed lymph nodes in the armpit usually, or the groin, the buboes. So E, lymphogranuloma, would be chlamydia, trachomatis. L1 to L3 would be small, painless ulcers followed by painful buboes, which are seen in the armpits and the groin, but you would not have any vesicles. All right, so the big things that I would say is this vesicular and this painful thing together makes us think we're starting from HSV somewhere. And what this does is it's a virus that actually hides in your sensory ganglia. And then whenever you are stressed, like you're studying for a big test, unrelatable, right? Or you have multiple sexual partners, or you have an illness and you start to have like this painful recurrent problem. You might have some systemic symptoms, might have like a fever, lymphadenopathy, and then you get and it's like, oh my gosh, look at that. It's a multinucleated giant cell. And the way that they'll show this on test day, they'll have like this, and then you'll just see like little tiny little clusters inside. That's what they mean by multinucleated. All right, so just don't overthink this one. All right, so just don't overthink this is just going to be genital herpes and then just move on, right? So here's our bottom line. I don't know, by the way, why I always do this. I just like put my face on this poor AI-generated character here, but clusters of vesicular lesions with multinucleated giant cells in zinc smear indicate genital herpes diagnosis. There you have it, folks. There you have it. You guys are doing so good today. For our next question, we have a 74-year-old man with a history of type 2 diabetes and hypertension presenting to the emergency department with a 3-day history of fever, malaise, and increase in confusion. He was recently discharged from the hospital 1 week ago after being treated for bacterial pneumonia, during which he had a central venous catheter for intravenous antibiotics. On examination, his temperature is at 102. Blood pressure is 110/70, heart rate 110 per minute, respiratory rate is 18. Lab tests show a white blood cell count of 14K with 50% bands. Remind me in the comment section to explain what on earth that means, the 14K and the bands. And by the way, by comment section, there's no way you can tell me right now, so don't worry, I'll remember. I'm just trying to like pump up engagement for no reason at all. But yeah, back to this patient. So we check this out, and then 48 hours later, boom, we got yeast. Which organism is most likely causative for this condition? And we got a lot of them here. When's it gonna be? Are we gonna guess? No. Well, maybe. We'll see. Seems like a strong answer. A is a good letter, right? Well, I don't see anything in the question stem about Southwest US and lung disease, and so I'm not going to choose that as my answer, okay? Because it's always going to have at least one of those two things in the stem, and I don't see either of them. Histoplasma capsulatum is going to be in Ohio and Mississippi river valleys. I feel bad because like medical school just like primes you to anytime like I go to Ohio or Mississippi, I'm like, watch out for the histo, and you just don't want to breathe, right? Because you're inhaling that stuff. Just kidding, you're fine. But it's a pulmonary infection, right? It's not going to be histo. All right, I'll skip C for now. D, sporothrix. Sounds like Bellatrix, but it causes skin infections, Rose Gardner disease. That one spreads through the lymphatics, not the bloodstream. And then Rhizopus, that would cause mucor in diabetics with diabetic ketoacidosis, but not candidemia. And candidemia just means fungal infection, right? It's where you have the Candida species like Candida albicans, and it enters the bloodstream, not the lymph, the bloodstream. And this is often seen in like healthcare associated infections, eyes, and this can be life-threatening. So you do have to treat it immediately. Broad spectrum antibiotics. Often you see this with indwelling catheters, that kind of stuff. Maybe they have a weakened immune system. Maybe they've got like HIV or chemotherapy going on. Symptoms would be like fever, chills, muscle ache, skin rash, confusion, and low blood pressure. Okay, and so our answer is indeed going to be Candida, any type of Candida. And Why is it Candida? Well, that is the most common fungal organism that's found in the blood, and it usually gets there through an IV catheter, as we spoke of. So we got this dude, look at him over here. It's actually me. Surprise. See, look, it's me. Anyways, just got out of the hospital and had a central line, was on antibiotics, and now I'm getting a spiky fever, and the blood culture is going to show yeast, and all that is just Candida, right? And in older adults, glabrata, Candida glabrata, although you don't really have to get that detailed, but that's like a tough little yeast that doesn't form true hyphae and it can resist azoles. But all we need to know is that this is Candida, and then we're good to go for this question on Le Step Uno. All right, here are the top answers and why they're wrong. So feel free to pause that if you want to dive deeper. The bottom line is blood culture, growth of yeast in a patient suggests Candida. By the way, I hope I'm not being too facetious. I just want to make sure you guys are having a good time while studying. It's fun to have a relatively fun video every now and again, as Rick says in Rick and Morty. A little horseplay is good every now and again. What does he say? In our next question, a 32-year-old man presents with a decreased libido and erectile dysfunction. He's got some low labs here. Prolactin super high though. MRI of the brain shows a pituitary lesion. The most appropriate pharmacological therapy is going to be what? All right, I've written some notes here in preparation for this question. What I want to explain now is prolactinoma, because that's going to be the first thing you're thinking of. This is a common pituitary tumor, and you get high prolactin. It's a prolactinoma, right? And what you have to know is that prolactin is a wet blanket. It likes to inhibit GnRH. It sees it at the party and it's like, no. It's like, is it Tim Robinson from I Think You Should Leave in that one sketch where he like tries to make the guy at the party have a bad time? That's what prolactin does to GnRH. And consequently, downstream to GnRH is LH. And if you don't have LH and FSH, then you're not going to have testosterone either. And that explains all of his labs and the low libido. And so like the lay of the land here is you look at the low T, you look at the low FSH and the LH, it's hypogonadism, and also the super high prolactin and the pituitary lesion of 9 millimeters. And all of that tells you we got prolactin secreting pituitary adenoma. So this is a prolactinoma. Also, by the way, it's important to like know what an adenoma is. I realize that sometimes we just throw words like this around and we don't even know what they mean. So an adenoma is a benign, non-cancerous tumor that forms from the glandular tissue, and it grows really slowly and it does not spread to other parts of the body. And so adenomas can occur in different organs, like the colon. Give some examples of the colon: tubular adenoma, villus adenoma, right? The pituitary gland, and that's what we're talking about right now, pituitary adenomas, right? Thyroid gland, thyroid adenoma, liver, hepatocellular adenoma, adrenal glands, adrenal adenoma. And so these causes can sometimes be unknown, but there are certainly factors like age, family history, hormonal imbalances, and all that stuff that cause this. And oftentimes you get these through physical exam, but sometimes imaging as well, or just biopsy. Usually they don't need treatment, but often you'll do, some observation and maybe surgery to remove the adenoma and then some medication to manage the hormonal imbalances. So we got a prolactinoma and that's causing decreased libido and ED. Hopefully that mechanism makes sense. Now, I want to talk about some of the associations because in this question we have a man, but this can also happen in a female as well. And so men with prolactinoma have decreased libido and erectile dysfunction. Women with prolactinoma would have galactorrhea, and the treatment in both cases is the same. The treatment is going to be a dopamine agonist. And this is where it gets so funny. And for you guys, I know there are some people who are taking the MCAT and they're watching another one of our YouTube channels. But dopamine inhibits prolactin, and prolactin inhibits GnRH, and GnRH causes LH and FSH to go up. And so I remember when I was studying for the MCAT way back in my youth that I was like, man, why do I have to keep track of all these long cascades? And well, this is a perfect example. Dopamine agonism would increase this dopamine, causing increased inhibition of prolactin, which causes decreased inhibition of GnRH, and the pathway just goes on and on. So the physiology here is prolactinomas secretes prolactin. Oh my gosh, surprising, right? High prolactin suppresses hypothalamic GnRH secretion. Low GnRH means low FSH and low LH and low testosterone. And so the symptoms are erectile dysfunction, low libido, and infertility. My friends, the bottom line is this. Prolactin secreting is treated with dopamine agonists to reduce prolactin levels and restore testosterone. All right, in this question, we have a 30-year-old woman who presents to the ED with severe abdominal pain. She frequents for severe complaints. She reports unstable relationships, chronic emptiness, emotional instability. Which personality disorder is most likely? All right, so anytime you have relationship instability, you should automatically be thinking of borderline. All right, paranoid is obviously suspicious about others without reason. Histrionic is attention-seeking, avoidant, social inhibition. Obsessive-compulsive is perfectionism and control, not emotional dysregulation. So she's got borderline. And how do you know? The repeat visits for dramatic physical symptoms, but normal labs. Chronically feeling empty and intense, unstable emotions. Intense, unstable emotions. This is one of the worst, absolute worst conditions for relationships. It can blow up people's lives. It is an extremely sad and serious condition, and it makes me sad just thinking about it. But emotional instability, impulsivity, and splitting. Splitting is the key thing to be thinking about for this one. All right, so that's all I wanted to say for this one. Intense emotional instability, tumultuous relationships, and remember splitting. Truthfully, one of the worst conditions out there. It's hard not just on the individual, but also on people who are in relationships or family members of those with borderline personality. All right, for this one, I have drawn the patient myself as a 4-year-old girl who's brought to the pediatrician by her parents due to recurrent infections and failure to thrive. The parents suggest that she mentioned she has had several episodes of bacterial infections affecting her skin and respiratory tract last year. Physical exam shows pale, thin child with petechiae and moderate hepatosplenomegaly. Lab shows pancytopenia and notably low neutrophil count. Bone marrow reveals the presence of immature blast cells, and they do not express these guys or CD19s, but they do express the 34s and TDT, which the following is the normal counterpart to these malignant blast cells. All right, hematopoietic stem cells of the bone marrow. Well, that'd be way too primitive, right? There would be no rearranged immunoglobulin genes yet. Immature myeloid precursors in the bone marrow. Well, myeloid precursors would be MPO positive, not TDT positive. And I'll talk about that in a second. Double negative T precursors in the thymus. That's a T cell lineage, and so that would rearrange on TCR, not the IG heavy chains. D is our correct answer. B, precursors in the bone marrow. The B cell lineage is, the precursors are going to be really timely here because this is before the CD19 expression. And mature natural killer cells in the peripheral blood. Natural killer cells do not rearrange immunoglobulin genes. All right, so it's a 4-year-old recurrent infections. And that is the age for acute lymphoblastic leukemia, right? ALL. And you can see pancytopenia. The reason is because the marrow can be replaced by the blasts. And there's rearrangement of the immunoglobulin heavy chain segments, and that's like a B cell lineage marker stuff. And there's no CD3, 4, and 8. And that CD3, 4, 8 tells you it's not T cells. That's super important. And there's no surface CD19, and that's a mature B cell. And then the CD34 positive and TDT positivity tells us that it's very immature lymphoid blasts because TDT is a marker for lymphoid precursors. And so the blasts are lymphoid, right? And we know they're lymphoid because of TDT positivity, but they're in the early stage of development. And they are B cell, and we know that since the immunoglobulin heavy chain rearrangement is like the hallmark of B cell development, but it's before CD19 expression. And so that comes later in the cell maturation process. And that's how we're able to kind of time this and say exactly where it is. That's why the answer is the early B cell precursors. Now, I promised I'd explain a little bit more about a commonly confused topic, but one thing I wanted to mention was this word, which you've probably seen, but maybe don't know how to say. But don't worry, a lot of us have trouble with it. Yeah, that's pretty hard to say, so let's just call it APAP. And that is normally metabolized through glucuronidation. And those are just two fancy words to say the primary phase 2 metabolic pathways in the liver that detoxify a wide array of endogenous compounds and foreign substances. They're called xenobiotics. So an example of those would be drugs, right? And by increasing the water solubility for excretion, they're able to detoxify stuff. All right, now conventionally, these are viewed as harmless, usually just inactive metabolites, and some conjugated proteins or some conjugated products can remain biologically active and become toxic. But we need to know the mechanism here. Like, it's super important to educate yourself about this. So a small portion via the CYP450 enzymes, especially CYP2E1, this guy right here, are going to be generating NAPQI. And that is a highly toxic metabolite. But usually the glucuronidation and the sulfation is like non-toxic. But there is this toxic metabolite component. But normally you have glutathione, and that neutralizes this guy, right? So it's like, hey, no worries, no big threat. But if you take a ton of this extremely difficult to say kind of thing, then you can get hepatocellular necrosis. And a big sign of the massive elevation of the AST and the ALT are going to present, it's going to be like greater than 1,000. And so you got to give them N-acetylcysteine, NAC, which replenishes glutathione. I felt inclined to kind of just put that out as a PSA so people know what this extremely difficult to understand medicine is. Yes, I'm being sarcastic. And instead of feeling fear, you should feel intrigue and curiosity, and you should pick up some science textbooks and just learn about the mechanism of action of these drugs. And you won't be as afraid. Oh, and then also I realized that I said AST and ALT, but I didn't really explain what those are. AST is a aspartate aminotransferase, and that is the enzyme that's found in many, many tissues. So the liver, the heart, the skeletal muscle, the brain. And so you might be asking, okay, well, cool. Why is the AST high in a liver injury? Well, in hepatocellular injury, like acetaminophen overdose, you have hepatocytes that die, right? You get necrosis from NAPQI that we talked about, toxicity. And of course, this is an extremely high doses. And then that causes the cell membranes to literally just break down. And then you get AST and ALT that just leak into the blood and the enzymes will spike. And that's how you get it all the way up into the thousands if you take a huge overdose, but you have to be taking tons. Like they'll say, it's like, oh my gosh, 16, 18 tablets, crazy amounts. And no, you will never be asked about autism and the link there, because that is fake science. And look, I always encourage everybody to study these things relentlessly. Don't take anybody's word for it, but the US Food and Drug Administration from Yale School of Public Health as of 5 days ago, and the CDC continue to recommend acetaminophen as the safest over-the-counter pain relief for pregnant women. And the studies, as far as I can tell, suggest correlation, but no proof at all that acetaminophen causes autism. So no causal link, that is to say, has been found in 2025 between acetaminophen and autism. Now, other factors like fever during pregnancy could be a risk for neurodevelopmental delay or genetics or other illnesses as well. But it's so important to know that correlation is not causation. And now they're doing a lot of like global studies on acetaminophen's effect on. In this paper, they're doing like 6 different areas of child neurodevelopment. But yes, it is still the safest over-the-counter pain reliever in pregnancy. Now, I will say that NSAIDs are not recommended after 20 weeks due to fetal risks. But the bottom line is always that you're going to use the lowest effective dose for the shortest duration. And also untreated pain and fever in pregnancy is more dangerous than taking acetaminophen. And there definitely needs to be more research before we say absolutely insane things to the public without having the facts to back it up. And by the way, the NSAIDs, just because we're preparing for step 1, would be like ibuprofen, naproxen, and aspirin high dose. That stuff, it works by inhibiting the cyclooxygenase 1 and 2. That's the COX 1 and 2 pathways, which decreases prostaglandin synthesis, and that leads to reduced inflammation and pain and fever. And so why 20 weeks, right? So why avoid NSAIDs after 20 weeks? Well, after 20 weeks, NSAIDs can cause fetal renal dysfunction because you decrease the urine, and that causes oligohydramnios. And so the fetal kidneys make most of the amniotic fluid. And so if you decrease the urine, if you have few urine, oligohydramnios, then you have decreased amniotic fluid. And then also after 30 weeks, then you have risk of premature closure of the ductus arteriosus. And that's normally kept open by what? The prostaglandins. So you shut it. And that leads to fetal pulmonary hypertension and cardiac complications, right? So there are like legitimate risks. It's not like people are just like saying don't do stuff or do stuff. Like by and large, people are trying to, I know I'm literally preaching to the choir right now. Like you guys are all going to become physicians, but maybe all the more reason to just stay informed and learn as much as you possibly can about these mechanisms and stay up to date. I like the Yale School of Public Health. Let's just say there are some other less reputable anything goes sites out there. Next up, we have a 45-year-old man participating in a physiology study where isolated skeletal muscle fibers are subjected to various patterns of electrical stimulation. The experiment utilizes a setup that records the force output of the muscles in response to the stimuli delivered at different frequencies. During one part of the study, the muscle is stimulated at intervals mimicking normal muscle twitch, muscle tightness, and various subaxial tensions. Submaximal, so just like not the highest tensions. Given tracings observed, when is the calcium uptake by the sarcoplasmic reticulum expected to be at its peak, allowing the muscles to fully relax? All right, let's talk about muscle relaxation, something that we do not get enough of as medical students for sure. That occurs, I know it's very rare for us, when calcium is actively pumped back into the sarcoplasmic reticulum, right? That's the process. The calcium goes back, and it is the fastest and most complete during the isolated muscle twitches with adequate time between contractions. Okay, so we have to know how the skeletal muscles contract and relax, the role of calcium in all of that, and the sarcoplasmic reticulum's role in releasing and reabsorbing that calcium. And so let's just talk about the calcium flow in the muscles, shall we? So if we dive down into the muscle, we will see, but you didn't know that it goes this far, but it does. There's a stimulation phase, and that's where action potentials, they open the voltage-gated calcium channels in the sarcoplasmic reticulum, and that causes the calcium to flood the cytoplasm. So now we got all this calcium in the cytoplasm, and then we go to the contraction phase. We move from stimulation to contraction. And so that calcium is going to bind to troponin C. All right, so we're binding to troponin C, and the tropomyosin then shifts, and you get the myosin-actin cross bridge, and that leads to the contraction. And now this relaxation phase, which is what this question was actually asking about, this occurs when the circuit pumps actively to return the calcium ions into the sarcoplasmic reticulum, hit that reset button, the cytoplasmic calcium then decreases and the muscle relaxes. All right, that's where our answer is during individual twitches with sufficient time between each stimulus. And SARCA, by the way, just stands for Sarcoplasmic Endoplasmic Reticulum Calcium ATPase. It's just that transmembrane pump that actively moves the calcium from the cytosol back to the sarcoplasmic reticulum and skeletal and cardiac muscle after the contraction occurs. So here's our bottom line. Calcium uptake peaks during individual twitches and sufficient time between stimuli, allowing full muscle relaxation. All right, this next question is kind of like the last one. 25-year-old male athlete presents to the laboratory studying the skeletal muscle, and his right bicep is isolated, and you get the stimulations, and we measure at different frequencies over a period of 10 minutes. As the frequency of stimulation increases, muscle's ability to completely relax diminishes. At which frequency is the sequestration of calcium into the SR expected to be most complete? All right, I know it's been a while since we've taken science classes in the MCAT, so it's been a while for me too. It stands for Hertz. And that just means the amount of times per second. So 1 Hertz is 1 event per second. 2 Hertz is 2 events per second, which arguably, if I'm getting really excited, I talk at like 3 or 4 Hertz per second. Just kidding. just, events per second, right? So 10 hertz, 10 events per second, you get the idea. It's just a fancy word for frequency. It's how often something happens. And so in muscle physiology, when a question says there's stimulation at 5 hertz, what they're saying is the muscle is being zapped 1, 2, 3, 4, 5 in 1 second, right? And so if you clap your hands once every second, then that's 2 hertz. If you clap 10 times, then that's 10 hertz, right? That's really fast. And we've kind of gone over this, but a higher frequency means there's less time between the contractions. And so there's the calcium that accumulates and you get the summation of the tetanus. And so the lower stimulation frequency would have the most complete calcium sequestration and the most complete relaxation between the twitches. So our answer is 0.5 hertz. And remember that the whole sequestration thing that can be confusing. That's just meaning like trapping or the isolating or storing of something. And so in muscle cells, after contraction, the calcium is taken back to the sarcoplasmic reticulum, and that is the sequestration process. So the S is just tucking the calcium away by the circa. All right. So think of calcium like confetti that you throw after a party. And then you need to go clean it up and you have to put it back in the box. That's sequestration. And if the party is happening every single second, then you don't have time to clean. And so there's going to be confetti everywhere. And so then the 0.5 hertz is like super slow, whereas the 20 would be super fast. Cool beans? Hopefully that was a nice kind of way to round out that question. Here's the bottom line. Calcium sequestration into the SR is complete at lower stimulation frequencies like 0.5. In this question, a 45-year-old woman presents to the emergency department with complaints of swelling and pain in her left-handed forearm over the past month. MRI has a bone growth at this C7 vertebrae, causing compression, and surgery is planned. Which nearby structure is going to be preserved or should be most carefully preserved? And honestly, this is kind of a subjective question, but it allows us to talk about a lot of things. So the C7 transverse process, and for this one, I'll actually give you 2 answers. And so first, let me say, if a patient has cold hands and numbness, then you should also be thinking about the arteries. And she's got a bone growth at her C7 near the thoracic outlet, and that's compressing the nerve and the blood supply. And so there's a very strong argument for the subclavian and the axillary arteries. Like, I'll give you both of them. But the vertebral artery passes through the transverse foramina of the cervical vertebrae, and that starts at C6. And so C7, the artery is really in the danger zone there. And so if you're doing a surgery to remove that growth, you could damage the vertebral artery, and that leads to a posterior circulation stroke. And so I'd probably be more partial to that answer. However, I completely understand if you said left subclavian artery as well, because that's super reasonable as well, just based on like real life surgical anatomy. But I do think the vertebral artery is the better bet just because it focuses on the C7 vertebrae, especially if we're talking about like the transverse foramina or the bony growth of C7. But just to make this like not confusing at all, the subclavian artery passes between the anterior and the middle scalene lateral to the C7, and the vertebral passes through the transverse foramina of C6 to C1. That's pretty close to the C7. The subclavian obviously supplies the arm, and the vertebral will do the posterior brain circulation. And again, I will totally give you subclavian artery because that is anterior to the scalene muscles, and it can be compressed in thoracic outlet syndrome, but it's a little bit less likely to be injured during like a vertebral surgery, but still it's possible. And then remember as well, thoracic outlet syndrome, and that can compress the brachial plexus and the subclavian artery and also the subclavian vein. But the surgery of the C7 would probably be the vertebral. So you have that bony overgrowth, right? The neurovascular bundle is affected. Blood supply to that hand is affected. And surgical resection then puts the vertebral artery at direct risk. Other things like the ulnar artery would be distal to the forearm and the wrist. Axillary artery would be lateral and below the clavicle. Radial would be the distal forearm and the wrist, and that's irrelevant here as well. All right, now with that being said, if you have a cervical rib surgery, then that would lean you more toward thoracic outlet syndrome. And the subclavian artery travels adjacent to the cervical rib and the scalene muscles. So the cervical rib, you should think of the thoracic outlet syndrome, especially compression of the brachial plexus. And here's the pathophysiology, and there are the key features for that.